Again, thank you for SMA for this wonderful platform. Again, it is my third year involved with your different assemblies, such as the Scientific Assembly as well as the Physicians in Training Conference, and it's always been a good experience. And I wish I could join everyone in Pigeon Forge today. First of all, I'd like to give thanks to my mentors, Dr. Okoli, Dr. Abdelghani, for really making this project happen. I'm going to be presenting about socioeconomic patterns of lung nodule referral and management in a minority predominant community. If I could add the next slide. Thank you. Okay, so why we wanted to do this study in the first place is that lung cancer screening, while everyone knows about it and USPSTF certainly recommends it, it has really been severely underutilized. While it's been shown on a very large New England Journal study, as you can see on the right side, that it both helps to detect lung cancer as well as prevent mortality from lung cancer. And this is such a useful tool that is currently being severely underutilized. In fact, per the latest study from CHEST back in 2020, only about 1 in 20 patients who are eligible for lung cancer screening actually get it. So, such low utilization rates really prompted us to look into this population, especially in our community here in New Orleans. And I would like to talk a little bit more about the demographic and geographical differences at play. Next slide. All right. So as we can see on the right side, again, I know it's hard to look at, but I'll kind of explain what I'm seeing here. So really, the lung cancer screening accessibility varies very greatly across different regions of the United States, and especially as you can see in the South, and specifically if we're looking at our state of Louisiana, it is one of the ones where this accessibility is at its lowest, unfortunately. And for our patient population, those that who are racial and ethnic minorities are often at even lower utilization rates for lung cancer screening, despite their eligibility. And so even though the latest study, again, published earlier this year in JAMA Oncology in 2022 by Dr. Pu and company, they did reported some improvements overall in national racial disparities regarding the utilization of lung cancer screening. This has not been enough progress made, and we really wanted to kind of do our part to investigating this issue. Next slide. So how did we approach to designing this study? Well, this is a retrospective analysis performed at the Pulmonology Clinic at Tulane, and we do serve a very unique community, and I'll kind of go through the demographics on the next slide. But the primary outcome of measure here, we wanted to really look at something that hasn't been looked at before, which is the interval that it takes from a patient from being referred for either an incidental lung nodule or a nodule that was described on screening to their initial clinic visit with us for the management of that nodule. And obviously, we're measuring other secondary outcomes, such as the change in lung nodule size between visits. What was their final diagnosis, as well as their disposition. So on the right side, you'll see that some of the different zip codes in the Orleans Parish, and I will be explaining the significance of that soon. So if I could have the next slide. So here are our patient demographics. So the first thing that you notice is it's a pretty even male-female distribution. We had 157 patients, the surprising thing, well, not surprising to us, but maybe surprising nationally, is that we have, again, a very minority predominant community here. About 44% of our patients were African American, and that's out of 60% of the New Orleans population is African American, and that is very high, compared to the national average of 13%. So I do think we really do have a good grounds to investigate this issue. And in terms of insurance data, as you can see, most of our patients do get Medicare coverage, and that's is explained by their overall older age. And you can also see that our population here is mostly most of them have not gotten higher education. So that is another factor that plays into the health literacy portion. So if I could have the next slide. Yes. This is the first portion of our results, and I just wanted to highlight a couple of things. First of all, the average nodule size. So it seems to be about 8 millimeters, which is if you know our lung nodule management guidelines, 8 millimeters is almost exactly that cutoff area where we define by size at least if a nodule is high risk or not. So that's an interesting little observation. Otherwise, from the initial visit to the follow-up visit, well, most patients actually do not experience a change in their nodule size, and in fact, a third of the patients actually experience a decrease in nodule size. And I want you to be able to correlate that with their final diagnosis. You can see, while most of our patients do turn out to have some sort of benign or infectious etiology for their lung nodules, there is about 6% of patients who do receive, unfortunately, a diagnosis of small cell lung cancer or non-small cell lung cancer. And I know that doesn't seem like such a high percentage, but six patients out of 100, I think we cannot consciously ignore that. And in terms of final disposition, again, most of our patients do continue to get CT surveillance with us. And on the right side, I just have two images. The top one showing a more of a larger spiculated nodule that hints at a more malignant etiology, perhaps. On the right side, we have a more of a peripheral, rounded, more benign looking nodule. Just to give you guys an example. If I could have the next slide. So this is part two of our results, and this is, we're really getting to the meat of the results here. So here we can see I've highlighted in yellow where we see some trends, and they were not significant, statistically significant, but they're trending towards that significance. As we can see, African American patients had to on average wait 5 days longer compared to Caucasian patients from being referred to getting their initial visit at our pulmonology clinic. And the same goes for patients who have Medicaid coverage. They had to, on average, wait 3 to 7 days longer compared to those who were on Medicare or had commercial insurance. And I will point out that the green highlight here means that we did achieve significance for this particular finding, is that Medicaid patients had a statistically again significant lowest rate for continuing CT surveillance. And this is again this is important to know, because as we can see, for people who are having Medicare or commercial insurance coverage, about 80% of them would ended up going through with that surveillance. However, there's a 10% decrease for the Medicaid patients. Only about 70% of those with Medicaid choose to pursue surveillance, and I think that's an important thing to keep in mind. Next slide, please. And then here we have even more trends, and I think one of the students who presented earlier mentioned about educational level and how that plays into health literacy. Well, we looked into that as well, and here we see that patients without a higher education compared to those who do, they have a trend to again have to wait 4 days longer to get that appointment. Now, multiple factors may play into why that is, but health literacy certainly is undeniably one of them. And then the last analysis here, I really do want to highlight the uniqueness of it, is that we looked into New Orleans zip codes, and we kind of ranked them by property values and how affluent they are, and we really took out the top 5 most affluent neighborhoods in New Orleans and compared them to the most underprivileged bottom 5 neighborhoods in New Orleans in terms of wealth. And we did actually find that people from underprivileged neighborhoods did have to wait on average, again, a whole week longer to get that appointment. And highlighted in green here, we see that again, patients from these underprivileged neighborhoods, again, uh, same trend for the Medicaid patients, they are choosing less of them are choosing to pursue CT surveillance. So again, a similar trend across the board, no matter which socioeconomic measure we look at. If I could have the next slide. So here, I just want to highlight a little bit more about our zip code analysis methodology. Here you can see the map. It's very clear. The green areas, the green zip codes. If you are familiar with New Orleans, you know that I am mostly, again, these would be the neighborhoods of Lakeview, of Gentilly, the Uptown. These are more affluent neighborhoods that are, again, pretty well known. And on the orange side, we have our bottom five zip codes in terms of wealth, and here we have downtown New Orleans. We certainly have, ranging from Central City to a lot of the more underprivileged neighborhoods. And here we can really, again, by comparing these two, we can really see that difference mentioned on the previous slide. And then I'll advance again. Thank you. So again, just well, what did we learn from this study? Well, I think we've definitely shown that patients who are racial minorities, have Medicaid, who are overall less educated and reside in these underprivileged neighborhoods really do show a trend towards longer waits from referrals to clinics. Now, again, you might say there are multiple factors at play here, of course, but this is something that, again, we cannot ignore. And this is a very unique finding in the sense that this is a disparity that exists despite our setting of a pretty minority predominant community. Again, just to remind you, 44% of our patient population was actually African American. So you could imagine if we were to conduct this study in a more Caucasian predominant community, perhaps the disparities we see would even be greater. And looking ahead towards the future, we really do want to increase the power of our study. We have only chart reviewed 157 patients across the past year, and I'm sure by expanding our retrospective cohort, we would actually be able to detect more statistical significance instead of just statistical trends. And then finally, I do want to mention, going forward, we have actually set up a brand new QI component to this study that will be currently running at the Tulane Pulmonology clinics throughout the next year. And what we're doing is that we're establishing a patient education program specifically on lung cancer and lung nodule screening. And on the right side, you can see our pamphlet that we've designed for our patients, kind of educating them on their eligibility based on smoking history, and what is a pack of, a pack of cigarettes. Some people may just, they don't really know exactly what that means. So we're educating them about pack years. We're educating them about the potential symptoms or lack thereof of lung cancer. And then finally, on the bottom right side, we do mention the fact that our patients from who are racial minorities and who are underprivileged actually do not pursue lung cancer screening even when they're eligible, compared to our more wealthy patients. And we wanted to make them aware that lung cancer screening is, it's covered by Medicare, and it's covered by any commercial insurance, and is completely free to them. And it's a service that they should absolutely utilize should they be eligible. And at this point, I think I've definitely touched on the main focuses of our project, and I would like to open up the floor to any questions. Thank you.
Thank you. We have time for one question. Okay, we have no questions. Thank you.
Thank you.